slides, right?
Yes, we see the slides.
I applied for core surgical training this time last year. I went straight from F2. So it's all very fresh in my head, and hopefully this talk will be useful for you guys. A bit about me. I went to Imperial in London. I ended up doing my F1 and F2 in not very far away, actually, in Chelsea and Westminster and Ealing, and then proceeded to start my surgery training program at Charing Cross and St Mary's, where I'm doing a plastics theme program. I'm doing general surgery, plastics for a year, and then ENT. So if anyone has any specific questions about any of these places, then feel free to message me. I will leave my email at the end. Feel free to ask questions like throughout this. Hopefully Anna can read them out, and then I can answer as we go. So I didn't even know where to start when I was preparing for my CST interview. So hopefully this talk will kind of increase your confidence in the content you need to know and how you'll manage your time when preparing for the interview. We're going to go through the structure and the competencies that they're assessing you on. We're going to go through some systematic approaches to tackling clinical and management scenarios using structured frameworks that you can always draw back to in these open-ended questions. We'll get you guys to kind of try and give some answers either through speaking or on the chat function to some frequently asked questions, and then can kind of give each other feedback to see what's good and bad. And then we'll also go through the leadership station and what the qualities of a good leader are and what examples you might be able to use for your interview. So yeah, this is kind of what's up. We will do the structure of the interview first. We'll go through the clinical scenario and how you can answer this with the CCRISP algorithm. We'll go through the management station and the leadership station. And I'm aware there's a new portfolio station, which we will touch on. However, I didn't do this station myself when I was doing the interview, as it's new for this year. And then lastly, we'll just go through some resources that you guys can use and some practical tips when preparing. So the general structure of the interview has largely stayed the same for the past couple of years and is very much the same even for you guys. There's just one addition of the portfolio station. The first station will be the clinical one. So although actually these can happen in any order in the real thing, and you should be prepared for that, it will be 2 5-minute clinical vignette scenarios, which are usually kind of based around normal acute things that you would see on the take, like surgical take in A&E, things like bowel obstruction, perforation, appendicitis, cholecystitis, that kind of thing. There may be a trauma scenario, road traffic accidents, stabbings, things like that. And there may be perioperative scenarios, so patients who are unwell either pre or post-surgery, and asking you to kind of give differentials and how you will assess the patient. In mine, I got an acute and a perioperative, but really you can get any combination of these two, or you may even get two of the same. The second station will be leadership and management station, so another 10 minutes. The management scenario is kind of a situation that may happen in the hospital that requires you to make decisions, and there'll be some ethical grounding around it as well. Again, they'll just give you a 1-sentence scenario, and they'll expect you to talk for probably about 3 minutes on what you would do in this scenario, followed by maybe 2 minutes of questioning. This station will then lead on to your leadership speech, which you will have already pre-prepared. They send you a kind of line on what they want you to prepare your speech on 2 weeks before the interview. but it's pretty much exactly the same every year, and we'll go through what it was last year during this talk. And then you need to get this leadership speech down to 3 minutes, and they will question you about it for 2. This, in my experience, is the best bit of the interview because you've prepared it all. It's the bit that you have the most control over, and you will have hopefully thought about some questions they might ask you and how you can answer them. And then lastly, there is the portfolio station, which is kind of marked on clinical skills and knowledge. There are sections on the mark sheet. One is for clinical skills and knowledge, one is for your judgment under pressure and prioritization, and one is for your communication. And each of these categories are weighted equally, so it's just important that you communicate well as it is that you have good clinical skills and knowledge. And it's just as important that, you appear calm, under pressure and think logically as it is any of these other categories. So don't just get bogged down thinking about all your knowledge. You need to also be really practiced at coming across well, thinking logically, and speaking to a camera as well. In each of these stations, you will have 2 interviewers, so you'll get a score from each of them, which will total up. And can I just quickly check, I'm going to do a poll. How many of you have actually done the CST interview before, just so that I know who I'm talking to here and how much experience you guys have? If you guys could click the answer in the poll, that would be great. Anna, is that coming up, by the way?
Yes, it's coming up, and we've got 11 responses until now, and they all say no. We have only had one yes.
Okay, that's absolutely fine, and that's fully what I expect. That's great. Just so I know where I'm pitching this to. So first of all, we'll go through the clinical station. As I mentioned, this will be 2 clinical scenario stations lasting 5 minutes each. It says they are provided during the interview to encourage you to think on your feet. These questions are usually like 1 or 2 sentences. They are quite general, something like a 79-year-old lady comes into A&E with abdominal pain, a fever and tachycardia. Please say your approach. And we'll go through exactly how to answer that, but I've just put a table here which is not intended to scare you. It's intended to be a kind of revision guide that you can come back to when you're preparing properly to see what the kind of common things are that come up. So I've put these into the 3 categories, which are the acute presentation, things that you might see in A&E. For these, you'll be answering questions using a CST approach, which we will go through. You may get a trauma station. The most common one by far is a road traffic accident. This comes up a lot, but also you can have a fall from height. An elderly person with a fall is sometimes classed as trauma or penetrating trauma. And then lastly, you can have perioperative options, which are just general things that you may encounter on the ward every day, and you'll use the CST approach for this as well. But yes, we won't have time to go through all of these, but yeah, you can look back to this when you get the slides afterwards. So I wanted to talk through the A to E or the CST algorithm, which is how you're going to structure the main bulk of your answer to the clinical station. Now, this is a bit more involved than your typical kind of A to E, and it encompasses a broader clinical spectrum than that, essentially. So I don't know how many of you have seen this before, but it's focused around, first of all, the A to E, and then the assessment that you will do after. And this is how you're going to structure pretty much your whole answer to the clinical question. So you'll start by going through your A to E, whereby we'll go through each one and the kind of things you're expected to say. So within the airway, you want to talk to the patient to ensure this is patent. Now, for each of the next of the sections, you want to think about how would you actually approach this if you were in real life assessing a patient. And by that, I mean think practically about the steps and how you would do them. So in breathing, first of all, you would want to get up-to-date respiratory rate and oxygen saturations. You would then want to examine the patient, look, listen, and feel. If the patient in the STEM, they told you that the patient had low oxygen saturations, this is the point where you'd like to say, I'd apply a 15-litre non-rebreather mask. And then lastly, you can consider an investigation such as a chest x-ray. And I know these are investigations, but because they're kind of critical things in the immediate management, I would say all of this at once. You then move on to circulation. Again, observations first. You would ask for an up-to-date heart rate and blood pressure. You would then insert a cannula, and I say this because some people say they would give fluids if the blood pressure is low or give antibiotics, but you can't do this if the patient doesn't have a cannula. So you need to make sure it's in this stepwise approach. So cannula first, then you will take bloods because that's what you would naturally do after putting in a cannula. You need to actually reel off all of the bloods that you want to take. So they want you to say full blood count, Usenes, CRP, LFTs, bone profile. You need to remember clotting, and you need to remember a group and save because this is a surgical station and they may go to theatre. And you need to remember a VBG to check the lactate. And blood cultures if the patient seems to be septic, which they almost always are. So don't forget blood cultures. That's one that people commonly forget. At this point, now you've got your cannula in, that's when you can give the fluids. That's when you can give the antibiotics, okay? And if it seems that the patient needs that in the STEM, this is when you'll say it. You can then consider some investigations like an ECG. If it's a trauma patient and they might be bleeding in their abdomen, you might do a bedside ultrasound, that kind of thing. But just you need to hone into what, I'm telling you all the things you might say, but you need to hone into what the patient might need given the information you've been given in the STEM. You'll then move on to the disability, where you'll say, I'd like to conduct a brief neurological assessment. I'd like to look in the patient's pupils. I would like to check pain level and temperature and administer any analgesia if necessary before completely exposing the patient, looking for any rashes, looking for any wounds, signs of wounds, infection, drains, lines, doing an abdominal exam, doing a PR if necessary, and very important in surgical patients, checking that the calves are soft and non-tender, particularly post-surgically. Then, very important, you say you have to recover the patients because often these patients are unwell and septic and cold, and if you don't recover the patient, then they're going to become hypothermic, and this is a thing they get a bit picky if you don't say. I know that what I've just said is a lot, but this is going to be the main bulk of your answer. You'll then move on this kind of flowchart to the full patient assessment. And by that, I mean things like gathering information, everything that's available to you. You want to check the drug chart, you want to check the notes, you want to check the op notes, and you want to check any available imaging or results. And this is going to be the same for every patient. So you can pretty much memorize a passage for this section that you're just going to reel off for every single patient because it's going to be the same. You then want to decide, is your patient stable or are they unstable? Now, in the CST interview, they're almost definitely going to be unstable, and you're going to then speak about your differential diagnoses, what investigations you'll do to answer these, and then any definitive treatment based on your top differential. Now, the examiner will not give you the answer of what the differential is, so you need to commit to a range of investigations that will investigate all of your differentials, and then come out and say, my top differential is X, and the way that I would manage this is Y, and then involve your senior and any wider members of the MDT. On the other side of the flowchart here, we have the daily management plan, which is more relevant if the patient's stable. Now, this happens pretty rarely, but it does happen, in which case you can show off by showing that you're thinking of things like getting a dietitian involved for nutrition and oral intake, looking at their drugs, looking at meds reconciliation, looking at PT, OT, and actually looking at when you can de-escalate patients, so when you can start to remove things like their catheter, remove things like tubes or drains, and move them to a lower level of care if necessary. So the structure of what you'll do, we've just been through the A to E bit and the parts after, but what I think is very important is an opening statement that you will make. And this isn't just for the examiner, this is for you as well. So you'll speak about what the salient points of that question are. And by repeating them out loud, it kind of focuses you before you start your A to E on what's important, and also tells the examiner that you can be trusted, you know what you're talking about. So I would say something like, this patient sounds critically unwell and I would attend to them immediately. I'm worried that they're hypotensive and tachycardic, and I'm worried they could be septic. Whilst I'm on the phone to the nurse or whoever's made the referral to me, I would like them to gather the observations, a fresh set of observations, and the drug chart and notes at the bedside. Now, that took me probably about 15 to 20 seconds, but it already tells the examiner that I know what I'm talking about and I know what I'm looking at, and I haven't even started my A to E. And in that way, they can relax a bit and know that you're focused in on what's important. You'll then start your A to E based on what we've just spoken about in the CRISP algorithm, and reel that off. By the time you get to your interview, you will know this so well. It's going to be pretty much the same for every patient, apart from you might stress some things a bit more for patients who are septic, like antibiotics and the sepsis 6, and some things a bit more for trauma patients, such as doing an ATLS approach. You'll then speak about information gathering, which will include your history, reviewing the notes and images, bloods, drug chart. Again, you can just reel this off. And then you come into your differentials and investigations and management, really. You will then remember to say that you will reassess your A to E after initiating any management to ensure that your interventions are having an effect. And lastly, you will make sure you escalate and discuss with seniors and the MDT. The MDT is critically important in this station because this will involve everyone from the nurse at the bedside being updated, your senior, people in theatre, such as the anaesthetist, the theatre booking team, the nurse in charge of the theatre, and any higher level or lower level care that you may need to transfer your patient onto, so ICU or an HDU bed. You might want to think about that. These are things that are going to really set you apart because there's a lot to speak about in this. And those who kind of remember all the MDT people, I think they really stand out in these answers. So we're going to do a sample question. This is a really common question which comes up time and time again in slightly different ways. And it's an important one that people are good at answering. So I wonder if anyone would like to volunteer to have a go at this question. And when I say that, you don't necessarily have to put your camera on, but Anna could make you a speaker if you just want to speak out loud your answer to this question. It's absolutely no judgment, and I'm not expecting anything from you guys in this. Anna, let me know if there's anyone who wants to give it a go.
No one has written anything in the chat.
Huh?
No one has volunteered in the chat until now.
That's fine. No worries. It is a bit daunting, obviously, to speak out in front of everyone.
I guess what we could do, if some people from the audience are in agreement, is that we could all do a little part of it and we could all volunteer some information.
That would be really good. Would anyone like to have a go at doing the opening statement, for example? Or if not, maybe someone could type it. So what in this question is making you worried? If you just type that in the chat. I mean, I don't want to have to pick people, but I might if no one answers, because this is quite important.
Oh, there's a volunteer, George.
Yep, so someone said they're worried about the lady's vitals and pain in the context of her recent surgery, and she'd require an A to E assessment and full review, which is completely right. We're worried that she's potentially a bit septic in the context of her recent surgery, which is great that you've picked that up, Anna. Does anyone want to have a go at the A to E? George, I saw you wrote you can give it a go. I don't know if it's possible for Anna to make you a speaker or not. We can see.
Yes, I have invited him to the stage, so he should be able to accept this request. And
yeah, I mean, it's a really good opportunity to do this because you have so many people to give you feedback, which is nice. George, are you there? Or if not, George, does anyone else want to have a go? It's just literally speaking through the ATE. I'm not going to ask you any questions about it.
okay, there is someone else. I will try to upgrade them now.
Okay. Oh, wait. No worries, George. Thank you, though. If anyone else wants to try, that's great.
Hello, can you hear me?
Yeah, thank you so much for volunteering. It's really brave of you, and also you're going to be great. So why don't you talk us through the A to E with this patient and what kind of things you would do when assessing this patient?
Yeah, of course. Actually, I would introduce myself to the patient. Obviously, if they're able to back, then the airway is patent. So then moving on to B, I would firstly assess the patient, doing kind of general observation, making sure that they're up to date, so their rest rate, oxygen saturations as well. And yes, and then doing a general inspection, seeing their work of breathing, bilaterally. I would then across the chest, listen to the chest, if there's equal entry, bilaterally as well. Yes. Do they give you any information, or is it just?
No, they don't give you any information. So this is a good experience where you can see how it works. They just got you to talk.
Just talking, okay, great. So, plus B, so obviously if they have low oxygen saturations, it's not written in the stem, but if there was low oxygen saturations, I would start with 15 liters non-breathable mask. If they're requiring oxygen, I would consider doing an ABG and a chest X-ray as well. And then moving on to C, so circulation, I would check the fluid status, check for any peripheral edema, membrane. I would also, get an up-to-date observations of their heart rate, blood pressure. That's it. And listen to their chest as well. I can see that they are slightly hypertensive and tachycardic according to the STEM. This could be due to dehydration, which is kind of the most commonest cause. So I would, actually 71, she could be quite frail, so I'll start with 250 milliliters bolus to replenish if she does have dehydration, and consider kind of doing an ECG and putting 2 wide bore IV cannulas, taking blood, full blood count using LFT, bone profile, clotting, liver function test, 2 groups in stage, so one taken now, one taken 15, 30 minutes later, and a VBG to check the lactate. I think that's all. That's C. Moving on to D, so disability. So glucose, I would check their glucose. I would check their pupils if they're even connected to light. I would check if they have a temperature. I can see that she is febrile, so possibly indicating sepsis, given that she's hypertensive, tachycardic, and febrile post-op as well. And I would then look everywhere else, making sure if there's any rashes, any lines. So she's had a resection. I'm checking her wound scars as well, if they're healing well. And I would ask her to open her bowels. If not, I would consider doing the PR exam. And I would continue to reassess afterwards as well. So to reassess if anything has changed and continue management. I don't know what more I can add, sorry, to that A to E. And then I would obviously gather more information, look at the notes, the post-op notes, see if there's any previous bloods before she left the hospital, compare it to the new ones, previous imaging. That's all I have so far. Sorry.
Great. How did that feel? How did you feel that went?
Because obviously they don't really tell you anything except for patients tachycardic and hypertensive without talking and indicating probably some sepsis or perforation or something along those lines, considering that she had a primary anastomosis.
And that's why it's useful to do this kind of exercise. So well done for volunteering, because you can see how strange it feels to, just speak on your own for 3 minutes. So I thought you did a really good A to E. You actually put some things in there that I didn't mention earlier. So that ABG is really important if they're not breathing. I thought it was really good how you said this lady, I don't know anything about this lady's oxygen saturations, but if she was hypoxic, I would give the oxygen. You covered the glucose in the D section, which I didn't even talk about, which is great. And yeah, I think to improve, you just need to, I'm not expecting this at all at this stage, but you'll come to it. You just need to keep rehearsing and get it a bit more concise. And as I was talking about earlier, in the right order practically. So, blood, cannula, bloods, then any fluids or anything like that. But really well done. That's great at this stage to be able to reel that off. And you actually went further and started telling me the information gathering after, which is great. So,
sorry, guys.
no, that's great. Thank you so much. I appreciate it. Thanks for volunteering. So, Aisha did a really good job there, which is great. And hopefully gives you guys a bit more of an idea of what's expected. So this is just what I wrote that I would say. This patient sounds critically unwell, and I would assess the patient immediately. Whilst I'm on the phone, I would ask the nurse to take some observations and collect the drug chart, fluid chart, and operative notes. On arrival to the bedside, I would assess the patient in an A to E fashion as per the CST protocol. This is my script that I learnt for CST. I'm not going to read it all out because I've probably bored you guys to death with A to E by now, and I think we've all got a good idea of what we need to say. But if anyone wanted to use this for reference when they're revising or trying to learn a kind of basic script, then feel free. This is just something that I wrote before. So information gathering, Ishita kindly demonstrated this as well. After performing my A to E assessment, I'd ask for repeat observations and reassess to ensure my interventions were having effect. I'd also like to take an ample history, review the notes, the operation note if required, if it's there, the drug chart, and available results and imaging. That's all you need to say. You just need to learn that bit as well. Does anyone have any differentials or investigations they'd like to do for this patient? Put them in the chat, or you can speak. I really don't mind. I'm happy. I would be happier if you spoke out, but you can put them in the chat if necessary. So I can go back to the scenario if it helps. Literally anything. We need to have probably at least 3 differentials to tell the examiner. So what do you think? Yep, so Anna's said anastomotic leak, CT scan. Yep, that is a strong differential. Does anyone have anything else? Perforation, post-operative collection. Yep, these are really good. So I would say kind of come up with 3 of your biggest ones. But in mine, they actually really pushed me to just list as many as I could. So I found the way to think about this easier as post-operative, like related to surgery or surgical complications, and then kind of nomosomal complications. So complications of being in hospital, like hospital-acquired pneumonia, UTI after the catheter, wound infection would fall into surgical, but you'll get a couple of things that you could say for pretty much any scenario that you'll be able to reel off, which is useful just to think of them in terms of medical and surgical complications. But yeah, there's some really good ideas there. Well done, guys. So just going forward, this patient has an anastomotic leak. This is a really common station. Day 3 3 to 5 post-surgery is the peak time this happens, and especially when you get one of the anastomoses is large bowel. Other options are septic or hemorrhagic shock. I don't think anyone said bleeding on the chat. Post-operatively, this is something that you always need to be thinking about. So make sure that if you say shock, you categorize it into septic and hemorrhagic. Other things may be perforation, obstruction, wound infection, hospital-acquired sepsis, and by that I mean our UTIs and our HAPs and such. I don't just shade you guys the answer. Can people write for me the investigations that you would consider? for these? CT, abdo, pelvis, yeah, great. Like pretty much every abdominal surgery, you're going to need to get this. I wouldn't go as far to say as every scenario you get, but every post-operative abdominal surgery scenario, you need to get this. Always a chest x-ray as well because of atelectasis or chest infection in the hospital. And more often than not, a abdo x-ray is useful if you haven't got the CT abdo pelvis. The investigations bit is quite easy, usually unless they're looking for something specific like PE. They're generally the same kinds of investigations. You'll say something like, I've already covered my bedside investigations and my bloods in my A to E approach earlier. However, for imaging, I would like to obtain an abdo x-ray, a chest x-ray, and a CT abdo pelvis with contrast. A sneaky question they like to ask is, what if you see gas under the diaphragm on your chest x-ray? Has there been a perforation? And you need to be careful because there may be pneumoperitoneum in the post-operative period. So don't get caught out by that one. Lots of people do. We're then going to go through our definitive management. You obviously don't have time to talk about this for all of your differentials. So you would say something like, having listed my differentials, my top one is an anastomotic leak. I would look to be starting antibiotics and fluids for this patient and making arrangements for them to return to theatre. For theatre, you need the same things every time. Patient to be nil by mouth, marked if it's a limb, consented, booked on CPOD, and alert your MDT. Bonus points if you alert the level of care that they're going to go to after, such as the ICU or HDU. By this point, this will be the station over. There may be a couple of questions. They didn't have time to ask me very many questions at the end. So yes, it's a lot of talking. You'll do 2 of these stations back to back, and this will only be a third of your interview. You'll then move on to your management and leadership station, and this will seem like a break compared to the first one. You will do your leadership speech, which we'll go through in a bit, which lasts 3 minutes with 2 minutes of questioning, and a management station, which is one station that's provided in the interview. You get 5 minutes allocated to answer this station. I found this station trickier to prepare for because you don't have the knowledge at your fingertips, but on reflection, it was much easier in the interview, and they tend to use very similar content every time. So more often than not, you'll get a station that you've already prepared for with your friends. So every station that you get, you're going to use this framework to ensure that you talk about it in a well-rounded approach. You may have seen the SPIES framework before. I saw something online where they made it SPIES DIR, and I found this a lot more comprehensive when speaking about these kind of stations. So first of all, much like the clinical station, you want to come in and do a summary sentence about what is the key issue in this scenario that they've just given you. It can encompass many things. Patient safety is nearly always one of them. So you can nearly always say, this scenario raises issues of patient safety. It raises issues of alcoholism at work, which therefore is patient safety. There's honestly all sorts of topics that can come up here. If you haven't said patient safety is a key issue, then you need to think about putting it in there somewhere because it always is. You then want to seek information, so find out more about the scenario. Who can you talk to? What notes can you look out at? There's always a way that you can find out more information about the scenario. You want to take initiative of how you can solve this scenario, escalate it to the appropriate people. Might be your reg, might be clinical governance people or people in admin roles in the hospital. It might be your consultant. It might even be telling the patient, a duty of candor if something's gone wrong. More often than not, these are pretty emotionally heated scenarios, and support is always a key thing to mention, whether it be giving the patient support, whether it be giving a staff member support because they have depression and they can't do their job properly, or they're taking drugs and trying to operate and they need, even though that's completely a scenario that should never happen, you need to think about giving your colleagues and patients support. You need to document any issues that have happened, incident report if appropriate, and I always say this as an extra thing, reflect in your e-portfolio or e-logbook and thinking about doing an audit so this thing can never happen again. Is like a little bonus extra, which I think they like people to talk about. I got full marks in this section, and this is the framework that I use, so I recommend this. Sometimes you can't say something about every single category, but if you kind of use it as a base, then you can't go too wrong. These are the common topics that come up. Again, we won't go through all of these, but if you use this later on in your preparation, then you can't go far wrong preparing a sort of scenario for each one of these. So, if someone wants to speak out, again, I really appreciate it. If not, what I'd like you guys to do for this scenario is give in the chat, give me a kind of SPIES DIR approach of what kind of things you think are covered here. So you are the orthopedic CT1. One of the patients has been admitted with a fall and a fractured neck of femur. Their PMH includes AF, COPD, CKD, and asthma, and they are very frail. It's the opinion of the orthogeriatric and orthopedic team that DNAR attempts will be futile, and you've been asked to complete the DNAR form with the patient and her son. The son is extremely angry on the ward and can even be aggressive that you will not save his mother. How will you proceed? And what I'll do is I'll just go back to the framework so that you guys can see it, because I accept this is probably the first time you're seeing this. And if you can just summarize in the chat for me some issues that you think come up based on the scenario. So to reiterate, you've got a frail patient who is on the ward with a neck of femur fracture, and your consultants asked you to put a DNAR in, and the son is angry and potentially violent. What will you do for each of these things? It's not my job to complete a DNAR as a CT1, I guess. Yeah, I think if you said that, then you're probably not going to do well in the scenario. This is very similar to what I got in my real thing, so you need to be prepared to answer these kind of things. Discuss what the son thinks, clarify any questions, try and de-escalate, explain what's going on, escalate to senior. Yeah, exactly. So, I mean, the key issues here are the patient's kind of psychological safety more than her physical safety here. We're going to be having a really emotional discussion, and having the son kicking up a fuss at the bedside is not ideal at all. You want to think about your own safety, someone who's potentially violent, and even staff safety around getting angry in a situation like this. It's these kind of things you need to think about. It's not just the safety of the patient, it's the safety of everyone around. You want to gather as much information as you can before going to the bedside to see the patient, to make sure that you're equipped to answer any questions that they may have. For the initiative bit, I think I said in mine, I'd like to take them to a quiet room away from the ward and away from other patients. It's distressing to kind of have patients overhearing this kind of thing. And as Anna says, the issue of confidentiality. Also, yeah, asking if the patient's happy for us to discuss this with the son too. That's a really good point, George. So you can already see by using this framework, you're getting so many ideas of different things that you can say. And this is why it's such a good framework to ensure that you've covered lots of different bases. If the patient is, you can escalate it to your senior. If the son's not happy, you can escalate it to security if the son is violent. Yaviz says, reassure the patient and family, saying we will make her comfortable attempting a seat. Yep, exactly. Reassurance is a massive part of this, and that comes into the support side as well. Not forcing them into it, giving them time to reflect on the scenario and saying, oh, I can come back in an hour or so to give you a bit of time to think about this. Offering like emotional support to the family as well. You need to document it, of course. There's probably no incident here, but if there was an incident whereby something did get nasty or aggressive, you would need to report that and do a DATEX. And then reflecting in your e-portfolio is always a good option as well to show that you're committed to improving in the future. So, well done for that, guys. There were some really good points there. I've put here, we've just been through all of it, but if you'd like to come back for reference, these are kind of the things that we would cover. So someone actually said ensuring the patient's happy with the presence of her son. Yeah. Reviewing notes, quiet room, for confidentiality as well, which is definitely an issue that could have been raised at the beginning. So thank you, Anna. Explaining, bringing senior members, reassuring, giving opportunity for further questions, and stressing it would be unnecessary trauma, and then documenting and reflecting. Okay, well done, guys. You've got really all of the answers there. So I now want to move on to the leadership part. They say they're going to give you the question 2 weeks before the interview. I mean, it's pretty much exactly the same question every single time, which is reflect on your leadership experience when working as a team and how this will be useful as a core trainee. You need to speak about this for 3 minutes, and I would recommend 2 or 3 examples, about a paragraph each, and each example has to be very point evidence explanation of these underlying words to show that you are fully answering the question. So I'm recommending the STAR approach, which is what's the situation, the task you did, an action, reflect, result, reflect. It's really important to put results to show that what you did had a meaningful contribution. You need data to back your claims, any prizes you've won, any outcomes of audits or kind of clinical research that shows that what you did is great. Don't hold back, this is the one time in the interview where you just need to say, I'm great, I'm great, I'm great. And don't pad it out, you won't have time. You need to time this whole thing to be 2 minutes 40, I would say, in case you stumble in the actual interview. You need to record yourself doing this over and over again, telling anyone who will listen, how do you think I can make this more succinct? How do you think I can get my point across better? But in the end, it ends up being the best bit of the interview because you have the most control, and you will, to be honest, be prepared for any questions I'll ask because you will have lived through, hopefully, these leadership experiences. So I've got a little Menti about just to get you guys thinking, what are the qualities of a good leader? And essentially, these I want you to think about kind of buzzwords that you might be able to put into your speech. Things that you think are important for surgical leaders. Are you guys getting access to it? Because I don't know if there's some technological issues, but I'm not getting any responses yet. So I'm not sure if you guys can see, but I see kind, organised, trustworthy, specific, motivating, hardworking. Yep, these are all really good answers. Managing people, calm. Yep, these are really great. And it's kind of these qualities that you want to get across. Think about someone who inspires you and who's a good leader. And what qualities do they have? And that's the kind of thing that you want to get across in your speech. And on that note, using the same code, it's all anonymous. Maybe you guys can give some examples of when you know, things that you might use. When have you been a good leader? What have you guys done? And I'll tell you if they're the kind of things that would be good in this kind of speech. Anyone got anything? Surely you guys are all very talented, I'm sure. You must have done lots of things. So I'm just looking at the questions, guys. How much of the teamwork stuff needs to come across? A lot of leadership stuff is very person focused. Can I give my examples? Yes, of course. So you really need to get within the team. I did an example of acutely unwell surgical patient on the ward, how I initiated management and got them to theatre essentially, and how they ended up having an ischemic bowel and they were saved. But that allowed me to speak about the management I had initiated and my leadership coordinating the team, and then working within the team and the MDT to get the patient to theatre quickly. I did an example of working in this leadership collaborative and some of the work that we had done together, which I had been the foundation leader, but I'd worked with my team in order to achieve things. And I did a non-medical example about being in a netball team, essentially. And I think they quite like a non-medical example just to show that you are a bit of a normal person as well. We've got some examples some other people have said. So program organizer for SFP events, delegated tasks to fellow members, successful events with positive feedback. Yeah, that's exactly the kind of thing you can say. So like you organized it, but you've delegated tasks, you know how to work with a team, you know that you don't have to take on too much. That's really good. Raising awareness of junior doctor mental health and improving well-being. This is such an important topic. I think you just need to pin down kind of what you've done, how you've led, and then how you've worked with other people to do that. But that's really good. Teaching programs as well, always really good. And another chance to show them that, you know, you're doing things outside of medicine, outside of like your designated job to help things. This is another chance to like really show off about things that you've done towards surgery that may not necessarily be included in the self-assessment, which I know they don't do anymore, but in the self-assessment categories. So think about that and think about, you know, what they want to see in a core surgical trainee. So great, guys. Thank you for all of that input. So I had a little brainstorm about what I'd done. I really wanted a research example, a clinical example, and an out of medicine example. And that's kind of how I went for it. I know some people who did all non-medical examples and did really well. And I know some people who did all research. So I think it really doesn't matter. But I just kind of thought best to show a balance. I read the RCS leadership guidance, which I've linked there. And I use buzzwords that they use within their own guidance to help frame my speech, which I think made a real difference. And I recommend you do that yourself. And then the follow-up questions are either specific to you or they can be quite generic. What's the difference between leadership and management? What qualities make an effective leader? How will you develop your leadership skills? They asked me this one I said I would do a LEAP course or formalise my leadership training, because everything that I had spoken about previously was on that. So I think any question that they say, how will you continue to develop, formalising with this is what I've gleaned from online. It seems as though your self-assessment part will be removed and it will maintain the same scoring system, but instead they'll choose two kind of topics to ask you about, and you need to speak about your highest scoring experience in those domains. So I guess that's the first thing to say. Write down all the domains, write down what your highest scoring example is. And it sounds really obvious, but make sure that you can talk about it in a logical and structured way. I find the STAR framework quite useful, and I also find the CAMP framework quite useful for personal questions. Things like, why do you want to do surgery? Talking about clinical, academic reasons, management reasons, personal reasons. Another thing I thought you could do is just match your audit proposal. So like if they're asking about a QUIP or an audit proposal, match the structure for which you would present that, like an abstract. If you're talking about research, you can do the same thing. I'm sorry that I can't be of more use for this station, but I didn't do it. You guys will be absolutely fine, I'm sure. Sorry, am I cutting out?
You're okay to me now.
Okay. So you said, how do we decide if you could speak about surgical or not? I think you should just choose your 3 best leadership examples, to be honest, and use that. I don't think they mind if it's surgical or not. As I said before, my friend did all non-surgical and got full marks. So it really doesn't matter, as long as you've evidenced the underlined parts of the question that show you're a leader working in a team, and why this will make you a good CST trainee. So you need that sentence at the end. This will make me a good CST trainee because... It sounds really stupid, but that is the best way to make sure you've hit all those points. I'm happy to take emails or stuff about the portfolio questions, and I can try and do a bit more research, but it's not what I did. Leadership experience needs to have been done after joining medical school. I think no, but there's some questioning over this. I think they prefer it if it's after. I don't know the answer to that 100%, Anna, I'm sorry. I would try and get it after. But then again, I don't know how they would know when exactly you did it unless they specifically asked you that. So it's up to you. I will try and find out for you and let you know whether it needs to be after or not. So guys, we're nearing the end. Thank you all for staying with me. Preparation timeline, I think I left it a bit late. I recommend 3 months, to be honest with you, because as you can see, there's a lot to get a grasp on, and you can't just do this last minute. You need to put in the time speaking to a buddy or yourself in the mirror. I think a study buddy is almost essential for this. You can't assess yourself, really. You can learn things, but you can't assess what you look like and how you frame things clearly. I practiced with Carl, who I think did a talk for you 2 weeks ago, and we only practiced together, actually, and I think it was really helpful. But practice current CSTs. If you see them around the ward, they will have just done it, especially CT1s, and they will know, exactly what to say. I really recommend recording yourself on the camera. I even did this right up to before my actual interview to check the lighting was good, that I looked okay. You need to speak to the camera. So currently I'm looking at the screen and you'll notice the difference. And then if I look at the camera, which I'm doing now, then you can like maintain much more eye contact, like you're actually speaking to the person, makes you seem much more engaged, and that's what's going to help you with your communication skill. So I would say it feels unnatural at first, but practice speaking at your camera, not at your screen, looking at yourself. It makes you come across so much better. And the speech, you really can't afford to get this out of time or not recall it. You need to write this well in advance and be able to recite it in your sleep. Some practical tips. Talk through your clinical and management answers without stopping. They don't like to prompt you. Signpost and use buzzwords when you can. Categorize everything you can. As I just said about the camera, it's so important. It takes a little while to practice it and get used to it, so I recommend doing that a couple of weeks before. And make sure you know where you're going to do your talk, what the lighting's like, and that you have good Wi-Fi. It's on a little chat kind of like video. I think it was called Cupacom that they did it. I'd never used it before. It was pretty easy to use. It's just like using Teams. So yeah. These are the main resources that I used. The Core Surgical Interview book is really good to kind of get a handle on things. It's a bit out of date, but I read this back to front and did all of the stations in it with Carl and some of my other friends. It was really useful, invaluable actually. I would definitely get your hands on that one. MediBuddy is a paid resource, but again, it has the same pretty much stations as in the Green Book, but it has a couple more. It's useful for structuring your answers. I shared the subscription with someone and pretty much just learned the answers to each of the questions. This is the Surgical Leadership PDF, which I linked earlier. It's really good to read this back to front for your leadership scenario. I watched a couple of things on YouTube and I didn't use this medical interviews book, but people told me that it was good, so I'm recommending it to you. And that's everything. If you have any further questions or need help with anything, I'm happy to answer. Or if you see me, if you're in Charing Cross and want to talk to me, then that's absolutely fine. My email's there, just in case you would like to send me anything. And I just have a look at the chat to see if anyone's got any questions. But otherwise, thank you all for coming.
Before you guys leave, it would be highly appreciated if you could just do the feedback for us, just to let us know how you think this session went. And it's also really helpful for Alex's portfolio, as she's working towards a qualification. So if you could do that, that would be fantastic. Thank you.
Yeah, thank you, everyone. And thank you for giving up your Monday evenings. I hope it was useful.
Thank you, everyone. See you next time with our Ranking Jobs webinar. Thank you. Bye-bye.
Thank you.